Alhamdulillah, wassalatu wassalamu ala Rasulillah. So I'm just going to go through some details regarding multi-parametric prostate MRI and the newly revised scoring system, PIRADS version 2.1. Just an overview of the talk. Firstly, I'll just give you some background information. Then I'll explain about multi-parametric MRI and what that entails. Then I'll touch upon the updated PIRADS scoring system. Then the next main topic will look at how MRI correctly used should fit into the diagnostic pathway. And there's a big study called, or an important study called PROMIS, and a few other studies, and also the guidelines internationally. Then I'll give you some case examples of different diagnoses, and then there'll be time for discussion, inshallah. Okay, so the problem with prostate cancer and diagnosing prostate cancer has always been a difficulty in detecting it. The tools that we've used to date have been quite imprecise. So the PSA is not a very good test. The blood test is not very good. And what we've done is, if the PSA is elevated, then they go on to have a unguided random transrectal ultrasound biopsy of the prostate. Again, it's just randomly sampling the gland. And then because we're using these poor tools, it means that we end up picking up cancer which is not actually clinically significant. The patient would die with it, but not because of it. And at the same time, we miss the significant, more aggressive type of cancer, which is clinically significant. And what's considered significant is at least Gleason 7. So this has been the problem historically. To try and resolve that problem, people have looked to MRI. So there's been quite a long history of MRI in the prostate gland. From the 80s even, just the simple sequencers would be used to stage cases. But gradually, over the decades, there's been development and refinement of multi-parametric MRI. And that's essentially using a number of different tailored sequences and putting the information together to get the best diagnostic accuracy. That's then been sort of formalized into a system of scoring and assessing these lesions. First, PIRADS version 1, which was then validated and then updated to version 2, and then more recently version 2.1. How do we use these tools? So we've got the fancy MRI now, we've got the PIRADS scoring system. Well, we can use it throughout. It should be in the context of prostate glands which have not been treated. Then you can apply the scoring, and then we can use it, to detect, localize, and characterize the lesions, and that can also help us to stratify risk for patients. And we may also use it for active surveillance as well in the right context. Okay, so a little more detail about multi-parametric MRI. What is it, and what are the exact? Well, the first basic sequence, if you like, is T2 weighted imaging. Okay, so it's a standard sequence, but we use, try and get high resolution images, and usually the tumor shows low signal on that. So here you can see there's a tumor involving the left gland, and in fact here it's extending beyond the capsule. Okay. And you can get other information. You can use it for staging. For example, here there's a nodule in the right seminal vesicle. There's possibly involvement of the bladder as well here. Yes, sorry, here there's involvement of the bladder as well. So the T2 is useful for that overview as well. The next sequence we use is diffusion weighted imaging and the ATC map. So I'm sure you'll be familiar with the principles of diffusion weighted imaging. I don't need to go over that again. But what you will see is that this is the tumor in the left prostate gland, which is low on T2, and you'll see that it's a high, it shows high signal, or it maintains its signal on the high B value, and shows corresponding low signal on the ADC. So that shows that there is genuine restricted diffusion. And we use quite high B value images. In fact, now we try and use 1500 to get that discrimination. And I think this is another example. So here you can see that there's a tumor probably in the right gland, which is showing low signal on T2. And you can actually put an ROI on the ADC map, and that gives you a quantitative measure, which may be useful. So here we would say it's 0.6 in the involved side, and it's 1.1 in the uninvolved side. You divide by 1,000. So that helps. That may help to quantify things if you need that. Now the great utility of ADC, of the ADC value or the ADC map, is that the value correlates with the Gleason grade, and this is the problem traditionally with prostate cancer, as I said, that we pick up the clinically insignificant cancer, but if we use the ADC value, that can help us. And this is a kind of scatter plot, but you can see that the trend is downwards, that the ADC value will go down as the actual Gleason grade increases. And this is another example, another paper where you can see that the ADC value, again, from a normal to low, intermediate to high grade, you get this drop in ADC. And that can help you to sort of stratify out the different cancers and hopefully pick out the more aggressive, clinically significant ones. And then the third main sequence that we use is the contrast enhanced images. And what we do for that is we give the bolus, and we have multiple acquisitions which are quite short in their time, in the time of acquisition. So it's a high temporal resolution. And then once you've acquired all that data, you can actually use software to get these nice maps to look at the speed with which the enhancement occurs and so on. And basically, wherever there's cancer, you'll get this rapid wash-in of contrast, and which is highlighted by the more red color. So that's the kind of fancy stuff you can do. But even on a simple level, if you just look at the basic images, you'll find that the earliest point of enhancement is potentially where there's cancer. So you just look at the very, very earliest enhancement of the gland, and then if you see a focal area, that suggests that there's cancer there. And you can actually look into the whole concept of the wash-in and wash-out curves, same as in breast lesions. Okay, you again get this very rapid wash-in, and then you get this wash-out. So that type 3 curve is also in keeping with cancer. Okay. Now, the point about the concept of multiparametric imaging is that each individual sequence has some degree of accuracy, but when you pool them together, you can get the most benefit from it. So you've got these area under the curve figures for the different sequences, and so they're reasonably okay. Okay, but when you combine them, you can actually improve the diagnostic accuracy. Okay, so that's an overview of multiparametric MRI. So what about PIRADS version 2, 2.1 even? There's a whole set of guidelines, and you can go onto acr.org and you can read up on them, if you're interested. But there are various things they mention. We need some level of clinical information about the PSA and so on, whether or not they've had a biopsy, other relevant clinical information. Okay. And then some points about the technique as well. It's very important that you optimize the technique to get good quality images. So if you have a 3T scanner, which we do, alhamdulillah, then you should use that because you get better signal to noise ratio, and you can get better, diffusion weighted images as well. If you don't have if you don't have 3T, you only have 1.5. You can use an endorectal coil, which can help. You should use Buscopan. That will help to improve the images. It's worth doing a T1 sequence just to see if there's hemorrhage from biopsy, for example, which can also give a low signal on T2. And you can also look for the nodes. And then you go to the high quality T2 images in multiplanar. Okay, and that's important that you get all the different planes on that. Then the diffusion weighted imaging, you use a number of b-values, but you do need the high b-value images to get good quality images. This is a trick which I like to use, is that you may swap the phase and frequency directions, because sometimes the ball gas can distort the image, which is problematic. So if you switch the phase and frequency directions, then that can just flip it around a bit and improve the image. And then the dynamic contrast enhancement, as I said, you need these high temporal resolution acquisitions, so multiple acquisitions again and again and again with a short time period. Okay. Some people say because the contrast is not always essential, so if the T2 and diffusion weighted images look perfectly fine, you actually may be able to miss out the contrast enhanced images. When you do this study, ideally the slice thickness and range and everything should be in sync. So if you've got the T2 diffusion and contrast, and then you can lock them and scroll through all of them together, and then you can cross correlate between the sequences. That's what you should do really. The ADC images, it's a good tip to have the window width and level set at 1400, and that helps to highlight the lesions. And when you measure a lesion, you measure it in the axial plane. Okay, so the next important thing which PIRADS emphasizes is the anatomical localization. So they have this multiple sector map of the prostate gland, and when you describe a lesion, you should precisely localize it, and then you can actually mention this terminology to clarify which part of the gland you're in. And this is like a sagittal image and a coronal image, and these are axial images, okay? And that's like the axis of the prostate. So you've got the base, the mid gland, and the apex, and then at these levels, base, mid gland, apex, you need to see exactly where you are: peripheral zone, transition zone, anterior fibromuscular stroma, okay? And the central zone will be more visible only in the base, really. And if there's BPH, you may not even see it at all. Okay, so the anatomy is particularly important because the score that you give depends on whether the lesion is in the peripheral zone or the transition zone. Okay, so if you start with the peripheral zone, okay, then the scoring is primarily based upon the diffusion and ADC. Okay, and if you go to the document, as I said, and again you can read this, I don't need to go into too much detail. But there's this stratification and a scoring system based on what you see. So if you have high signal on the high B value and low signal on the ADC, okay, then that's going to be at least a PIRADS 4, okay? And if it's above a certain size, okay, so it's above 1.5 centimeters, then it becomes PIRADS 5, or if there's some extension beyond the gland. And then there are further grades, as you go to a lower score, then you have more detail to explain that, okay? Now the transition zone, the focus for this is really on the T2 weighted images. Okay, so again you have a scoring system from going from 1 up to 5. Okay, so the point here is that in BPH you will get these well circumscribed nodules, which we know as BPH nodules. Okay, so you get the well circumscribed nodules. There may be slightly reduced signal and so on, or they may be just a bit ill-defined. You're not sure about it. Okay, but if you have a kind of ill-defined lesion or something which is not a nice round shape, but it's kind of lentiform, lenticular shape and so on, or it's above a certain size, etc., then you're going to be more worried. So then you'll give a score of 4 or 5. Okay, so that's what you need to look out for. And just a tip as well is that I'll probably show you this in an example as well, that sometimes if you're having difficulty assessing a nodule, have a look at the coronal as well, because that can sometimes tease things out for you. Okay, and the dynamic contrast enhancement, the scoring is simpler in some ways. So basically you just see, you look at the earliest beginnings of enhancement in the gland, okay, and if you don't see anything focal, then you're okay, okay? But if you do see something which really stands out at the earliest or just before the earliest enhancement of the rest of the gland, like this lesion, for example, okay, then you should be concerned, particularly if it corresponds to a finding on the T2 weighted and diffusion weighted images, okay? Okay, so once you've got all that information, then you put it together and you get an overall score. So as I said, you've got the basic score. You've got 1 to 5 for the peripheral zone, which is diffusion, and you've got 1 to 5 for the transition zone, which is based mainly on T2 weighted images. But if you look closely, you can see that there'll be certain situations where you need to look at a tiebreaker. Okay, so if you take the peripheral zone, if you've got a score of 3 on the diffusion weighted imaging, and that's sort of intermediate, then you look at the contrast. Okay, so if the contrast is not showing anything particular, then it stays PIRADS 3. If the contrast is positive, then you get upgraded to PIRADS 4. Okay, that's quite important. And then similar kind of principle with the transition zone. So you look at the T2 weighted images. If you've got so if you've got a score of 2, then you look to the diffusion. Okay, so you can get upgraded to 3 if there's particular restricted diffusion, score 4 or 5. Okay, and if you're on a score of 3 to start with, then if you have particularly restricted diffusion, i.e. score 5, then that can upgrade you to a score 4. Okay, so that's useful. The utility of that is to basically reduce the kind of number of indeterminate scores. Yeah, so you can give a more definitive conclusion. Okay. So once you've done all that, then you get a final score, okay, for a lesion, for each particular lesion, okay? And so you go from a score of 1 to 5. So 5 is a very high probability, down through high, intermediate, low, or very low probability of clinically significant prostate cancer. Now, again, the point here is we're not trying to pick up every single tiny focus of prostate cancer, even the low-grade stuff. We want to miss out the low-grade stuff and pick up the clinically significant prostate cancer. Okay, and this is the final score that you'll get. So that's kind of how it all works. So we've talked about the multiparametric MRI. We've talked about the PIRADS 2.1 and how the scoring and all that works. Okay, so we've got this wonderful tool. How do we actually fit that into clinical practice? Okay, how does it work in the real world? Okay, this is where I want to talk about this study called PROMIS. Okay, and this is quite a important and pretty up-to-date study. I mean, it's 2017 when it was done. And this is really gives a strong evidence base for the power of MRI and for using it as a first step. Okay, so we use it as a first step before the biopsy. Okay, so I need to explain the actual study to help you understand how it shows this. So basically, they had a recruitment pool of about 600 people. Okay, they did the multiparametric MRI, okay, as described, okay, as I've explained to you already. Then they did this thing called transperineal template mapping biopsy, okay, and that's the gold standard assessment. And it's quite, it sounds like a quite brutal torture almost, but it has to be done on a general anesthetic as well. But what they do is they have this kind of grid with multiple needles or multiple sites for needles, and it goes through the perineum, and basically it systematically samples the whole gland. Okay, so the whole prostate gland is systematically biopsied and mapped. Okay, so that's like the gold standard that we can do, if you like, to look at what the pathology is. Okay, and then they went and did the standard transrectal ultrasound, random sampling biopsy. Okay, So you've got now the MRI, you've got the usual practice, which was the random trust biopsy, and then you're comparing them with the gold standard. Okay, that's the power of the study. Okay. What they found was that in those cases, they found prostate cancer in about 70% of cases. Okay. The CS, clinically significant prostate cancer, was 40%. Okay. So note the difference in those numbers. Okay. And so for looking at the sensitivity and specificity, they found that the MRI compared to the gold standard, sensitivity and negative predictive value was much better than the trust biopsy. Okay, so there's quite a significant difference there. Okay, and the specificity and positive predictive value is not so good, and that makes sense because if you do find cancer on the random trust biopsy, you know it's cancer because you've got the biopsy, right? That's not what we're trying to do with the MRI. Okay, the point is that then you should biopsy. If you do the MRI, then you should biopsy. Okay, but what we want is the MRI to give you that confidence that if the MRI is normal, we can be confident, say, okay, there's nothing significant here. We can be reassured. So that's really where the power of the MRI comes in, and that's what the study shows quite nicely. So based on this and based on their analysis, they said that, look, the standard pathway is we do the trust biopsy and then we see what's going on and then take it from there. Okay, that's the old school, if you like. The new idea is let's do the MRI first, and then we can actually and then assess whether or not there's significant cancer, and if there is, then we can biopsy from then on. Okay, so if we do it that way round, then MRI first means that nearly 30% of patients can avoid a biopsy altogether. You do the MRI, say it's normal, okay, khalas, that's fine. We don't need to biopsy and we can be reassured. Okay, and the great thing about MRI is that it actually you're still in a stronger position diagnostically because you're missing the insignificant cancer. You reduce the diagnosis by 5%, and you increase the diagnosis of clinically significant cancer by about 20%. Okay, so not only are you reducing the number of patients having a biopsy, you're actually improving your diagnostic yield and accuracy. So it's really quite a strong argument for MRI and doing MRI first. Okay, so the bottom line is keep calm and have an MRI. Okay. Now, the other studies which have actually gone on to look at this further, where they've actually tried to sort of implement the MRI into the pathway and see if it actually helps. Okay, helps or not. So there are 3 studies there: Precision, 4M, and MRI first. And what they found was that, and again comparing it to trust. Okay, so what they found is that if you look at these columns of insignificant prostate cancer, you're reducing the percentage of insignificant prostate cancer being picked up when you do the MRI first. Okay, you're increasing at least equal, if not increasing, the percentage of clinically significant prostate cancer, and you're able to avoid biopsy in a significant number of patients. So again, this shows that in the real world, when you actually implement this, you're actually still benefiting. So because of this very strong evidence base, there is now incorporation of MRI first into diagnostic pathways. And here are some examples. So this is the NICE guidelines, which is the UK standards body, if you like. Okay, so they say that we should offer multiparametric MRI as the first-line investigation for people with clinically suspected prostate cancer. Okay, and then you take the assessment from there. Okay, so you can omit the prostate biopsy if the MRI is normal. You can be reassured from that. Okay. Another example, NHS England, again, similar kind of point that we should be doing the MRI first and we can be reassured if that's normal. Okay. European Association of Urology also similarly says we should use prostate MRI before a prostate biopsy. Okay, so we can actually use that approach. Okay, so that's a kind of overview of the whole story so far. What I want to do now is give you some case examples. Okay, so this will give you, and it's just a taste. I mean, there's a lot of cases I have, but I've just selected some to give you some lessons about what's important. Okay, or some important principles. So this is a normal examination. So I just want to show on this one really how we should try and delineate the anatomy of the gland, and this is really important. Okay, so you're going from the base to the apex. Okay, and you've got the peripheral zone. Okay, and the transition zone. Actually, there's not much transition zone in this case because there isn't much BPH. Okay, but this is the transition zone. Okay, and the little dark patches here, that's the central zone, okay, which you probably won't see well if there's BPH. Okay, so you need to translate what you see into the sector map. Okay, and you can actually work it out and draw colors if you like. Okay, so this is another case where it's a good example of BPH. Okay, so look, the gland is pretty massive. Okay, and it's really the transition zone is enlarged, and you can see that sort of stained glass window appearance of the tissue where you've got these nodules. They show varying sort of shades of gray, but if you look, all the nodules are pretty well circumscribed. Okay, they're pretty well circumscribed discrete nodules, and if you're not sure, you can cross reference in different planes. Okay, so you can be reassured that that's probably normal. Okay. And this was confirmed on biopsy that there was no malignancy. This is a nice example. So this is when the patient had a biopsy already. So they had elevated PSA. They'd had the random truss biopsy, okay, and that was negative. And this shows a problem with truss because you're coming from the rectum and you'll sample the posterior gland better, okay. So they had all that. That was all negative. So then we did the MRI. And then you can see, look, okay, there's obviously a lesion. It's anteriorly left anterolateral gland, and it's low signal on T2. It's a restricted diffusion. Look how dark it is on the ADC. Okay, and it's also enhancing. Okay, so you've got a full house. This is it's clearly concerning. It's PIRADS 5, and the biopsy confirmed that. This is another case where I think it's a similar concept. So you've got a lesion anteriorly in the gland. This is the anterior fibromuscular stroma. Okay, so you've got low signal on T2. You've got restricted diffusion because it's low signal on the ADC and some enhancement there. Okay, so again, this is also positive. Okay, PIRADS 5 and it's positive. Okay. This is another example. Again, shows that you can pick up quite small lesions. Okay, so here you've got a small focal lesion. It's low on T2. It's high signal on DWI with low signal on the ADC, so it's restricting, and you've got that enhancement. So again, you can see that relatively, it's relative to the rest of the gland, it is enhancing. Okay, so again, it's PIRADS 4 because of the size. It's not big enough. Okay, but that was Gleason 8. That was confirmed. This is just another example. There's no contrast on the study, but you can see there's low signal on T2. There's some extracapsular extension there. Okay, and you've got restricted diffusion there. Okay, so low, high B value, and low signal on ADC. Okay, so it's PIRADS 5, extension beyond the gland, and that's positive. Okay, this is another case where a chap with elevated PSA, and you've got the peripheral zone, and you've got some streaky signal reduced signal on T2. It looks like there is some restricted diffusion because there's increased signal and there's reduced on the ADC, and it's also enhancing on the post contrast. Okay, so we said this is a PIRADS 4, okay, because of those findings. But what we found is that actually this was prostatitis. Okay, so this is the thing you need to be careful of, that prostatitis can mimic cancer on the MRI. And the thing to look for is that if you look at the T2 weighted image, it was very streaky and vague. So that suggests more prostatitis than an actual. This is another case. It's quite a high PSA. Okay, you've got diffuse slow signal on T2, enhancement and so on, restricted diffusion. Okay, and this was an advanced case actually. So it's actually involvement of much of the gland. Okay, so all the sectors biopsy showed high grade tumor. Okay, so this is another case where again this is a more advanced case. Okay, so you've got different slices through the level of the bladder, seminal vesicles, and higher up in the pelvis. Okay, T2 diffusion ADC. Okay, and you can actually see that the seminal vesicles are involved. Okay, and it's actually even going along the ureter, and you've also got enlarged nodes in the pelvis. So this is a more advanced case. Another nice trick you can use for prostate imaging is if you invert the diffusion weighted image, you can actually it actually highlights where nodes are. Okay, that can sometimes help to pick them out. The actual ADC score and so on doesn't help differentiate, but it just helps you to see them better. Okay, so here's a node which you might just pass by. Okay, you might pass by that node, but it's very obvious on that inverted diffusion weighted image. Okay, this is a case where very high PSA. Okay, what's going on here? So there's low signal on T2, diffusion, it's a bit difficult to make sense of. Okay, but actually the key thing here is that on the T1 weighted image, there's a low signal lesion. Okay, so that's M1. Okay, so do remember to look at all the other sequences as well carefully. Okay, and now this is quite a nice case. So this is a case where the patient has had treatment, so PIRADS is not relevant now, but they had high-risk prostate cancer, they had prostatectomy and positive margins, and despite radiotherapy, the PSA is climbing. Okay, so the question is there recurrence? Okay, so if you look at this on this image, you can see there is actually a lesion at the sort of neck of the bladder or just above it, which is sort of intermediate signal on T2. You've got restricted diffusion, relatively speaking, on DWI and ADC, and it's enhancing brightly. So what you find with these recurrence cases is that they really light up on the post-contrast. Okay, so this is what we can see. Okay, you can see that there's enhancement there, and in fact, further inferiorly at the perineum, there's another focus. Okay, you'd be hard to find that on the T2 and on the other sequences, but look at the contrast. Okay, it's really lighting up like a light bulb. I think that's it. Those are the main cases I had. And just to review, we talked about the problem with diagnostic prostate cancer, and then the power of multiparametric MRI. We talked about PIRADS 2.1 and how the scoring system works, and then we talked about how that should be incorporated into the diagnostic pathway based on the evidence, like the PROMIS study. Okay, so that's really powerful, and the other studies as well. They really show that we should be doing MRI first and then biopsying. Okay, and then we have the case example. So I hope that clarifies things, and I hope if there's any questions, then please